Greetings, everybody, and welcome to Question Lab, episode 180. I'm Jeff Downing, and I have to tell you, there's something kind of beautiful about 180 episodes of anything. It means we've gathered here 180 times with med students from California to Ghana, struggling with some of the same questions. So we are happy that you have joined us so that we can focus our attention on the respiratory system. So tonight's episode is going to center on questions involving the respiratory system for step one. I'd like to introduce my co-host, Dr. Abraham Titus. Abraham, would you like to introduce yourself to the crowd?
Sure. Thank you, Jeff. So my name is Abraham Titus. I am a Hematology and Oncology Fellow at the University of South Alabama. I've been, coach with RX for quite a bit now and helped many students such as yourselves through your step 1, step 2, and step 3. And I'm excited to be here and go through some high yield respiratory for step 1.
And just kind of, tell you a little bit about what we're going to do. Obviously, USMLE-Rx and our team here from Scholar-Rx works to put together these sessions for you. We've picked out a bunch of questions from QMAX that are both representative and challenging. And as a part of that, we obviously like connecting on the content here, but we also like to provide tips regarding methodology. So as we go through tonight's session, you're going to see us, follow the protocol that we've developed for a lot of our students. So essentially, what we do is, we start with the lead-in. We cover up the answer choices, then we start with the lead-in, then we go to the vignette, and then we work through the answer choices in reverse order. So again, you may already have your methods for answering step questions, but if you don't, or if you're looking for ways to even to sharpen your technique, hopefully we'll have some things here to help you improve. Okay, so with that, we're going to go ahead and get started with question number 1. And again, as I open this up, what's missing? That's right. We're missing the answer choices, and again, that is by design. We do like to cover up the answer choices. Part of it is it's really about focus, and as med students and as students preparing for board exams, I think you all understand the value of focus in an increasingly distracted world. So one thing we don't want you to do is see an answer choice on something that's confused you, or that maybe you just feel like you don't understand very well. We don't want to undercut your confidence, but more importantly, we really just want you to focus on these, each specific element one at a time. So the first thing we ask you to do is cover up those answer choices. Then we say, read the lead-in. And if you are new to board style questions, the lead-in is the actual question here. So for question number 1, the lead-in is, which of the following molecules most directly contributes to this patient's symptoms? The lead-in obviously is another focusing tool. If you read the vignette first, and the vignette is the scenario that supports it, that's where all the data is, right? But you may not necessarily know what you should be really focusing on, or what it is you're trying to get to. If you don't really know what the goal is, you may just try to absorb things that are either irrelevant, or you'll have to kind of go back to it. So knowing that you're going to be trying to determine molecules most that are contributing to a patient's symptoms, now you can read the vignette almost as if you've kind of got a compass, right? You've got a way to steer through this question. Okay, so with that, let's go ahead and read the vignette. A 3-year-old boy is brought to the emergency department by his parents because he is having difficulty breathing. He recently had a mild upper respiratory infection, which has since resolved. On physical examination, he is afebrile, respirations are 33, and oxygen saturation is 91% on room air. He appears to be in respiratory distress. On auscultation, wheezing is present in all lung fields. So again, the question, which of the following molecules most directly contributes to this patient's symptoms? In your mind, you may already be thinking of potential molecules even before we reveal these. So think about that as I pass it off to Abraham.
All right, thanks, Jeff. So he did mention some really important points there about being able to understand what the question is about, really building a differential in your mind and having an answer kind of thought about before you even look at the options. So let's go through, let's highlight some keywords here. And then again, we're going to focus in really on the lead in here. So again, lead into most directly contributes to patient symptoms, right? That's not about the diagnosis. They're not asking about what's going on, but which molecule directly contributes to the patient's symptoms. So that's really what's important. You want to think about what's happening, think about the diagnosis, and then get to kind of understanding the basic science of it. It's kind of a very typical classic step 1 style question. We're asking kind of a basic science side of it. So let's go through then I like to highlight some keywords here and kind of build a story based on the vignette. So we know it's a 3-year-old boy. He's in ED, so he has difficulty breathing. He had recent mild upper respiratory tract infection. So, okay, those can, cause some issues there. His respirations are pretty fast, 33 a minute. And he's satting about 91% on room air, which is pretty low for a 3-year-old. And he appears to be in respiratory distress. And there's wheezing in all lung fields when you listen to him. So you should, from the story, you should already kind of have an idea of, okay, what's going on with this kid and what's happening. But then the question is not just the diagnosis, it's about what molecule is contributing to the patient's symptoms. So take a second, think about it. You can drop it in the question box if you think you know what the answers are ready. But let's pop the options open right now while we start kind of thinking about these differentials in our mind. So we have our classic 5 options here. I like to start with E and read my way up. There's no particular reason for that, but you just have to make sure that I go through every single option and don't just pick with the first one that I think. So option E, thromboxane A2. Option choice D, prostaglandin E2. Option C, prostacyclin. Option B, leukotriene C4. Option A, interleukin 1. Very step 1, so this is your basic science, understanding kind of what's happening at a very molecular and cellular level, what in this patient having this wheezing episode after this recent upper respiratory tract infection. So take a second, pick the answer that you believe is the best answer that would fit the situation as we pull up the poll in the next little bit.
And let's share the results. So pretty strong consensus here on leukotriene C4 as being the molecule most directly contributing to this boy's symptoms. There's a tie for second place between prostaglandin E2 and interleukin 1, and a couple of votes for prostacyclin and thromboxane A2. So let's close the poll. And let's see the answer. And the answer is answer choice B, leukotriene C4. So guys, you did a great job. Nice way to start the evening. Good job. If you didn't get it right, that's okay. Then this is really the important thing about Question Lab. Whether you get it right or wrong, we really want to spend time breaking it down so that if you got it wrong tonight, you'll get it right on test day. And then also, if you got it right, let's just make sure you got it right for the right reasons. So Abraham, can you walk us through this one?
Sure. Well, good job, guys. Clearly, a lot of you guys have been paying attention in your early basic science pulmonology classes, and that's kind of really what this shows off here. So we are dealing with leukotriene C4 as a main cause. So let's go back and look at the story, right? So the patient is this 3-year-old boy. He got a recent upper respiratory tract infection and then is having this wheezing. This is classic presentation of asthma, right? So asthma is one of the most highly tested things on step 1 and step 2 and step 3 because it's so common and it's something that you will see in your clinic or hospital. A patient, typically present with like tachypnea. They can have this bilateral wheezing that takes place. And then there's usually some kind of trigger, either viral illness, allergic trigger, whatever it is, something triggered it. And asthma, we know it's this chronic inflammation, there's mucus plugging, reactive airways, and that leads to these bronchoconstriction that leads to issues. Now, this question, I expect you to know all of that just from reading the story, but the question is asking about the molecule. So you have to kind of really get into that arachidonic acid pathway, right? Think back to your step 1, there's that classic high yield chart where they go into the phospholipase A2, going into the arachidonic acid, and they break down into the COX pathway and the LOX pathway. And kind of you can figure it out from there. So let's go through, let's kind of label what each of these are, and particularly leukotriene C4, which is the answer in this situation, why that is the answer. So we know that leukotriene C4, D4, and E4 are all going to be together. These are our leukotrienes, which then promote vasoconstriction in this situation. So we have, these are the ones that kind of mostly regulate that bronchoconstriction. Sorry, misspoke there. Bronchoconstriction and inflammation. These are pro-constrictor, pro-inflammatory mediators in this situation, particularly triggered in asthma. And that would be, that's why it's the answer. What about the others, right? So we have a bunch of these other interleukins and prostaglandins. Let's go through them. So I think we'll start from the top and make our way down here. So interleukin 1, IL-1 is always think fever, fever, fever. So these are the ones that are implicated for any kind of inflammatory cytokine response that's associated with like infections and fevers, metabolic syndrome, diabetes that also have an association with these as well, but not particularly implicated in asthma. Prostacyclin is a good thought. We also call it sometimes prostaglandin I2. This is a product of the COX pathway, cyclooxygenase pathway. So it's just more with platelet aggregation and vasodilation. So it inhibits platelet aggregation and promotes vasodilation. A lot of these may feel like memorizing, but if you really just break down that arachidonic pathway and you kind of take a chance to understand, there are two opposing prostaglandins that work against each other and kind of learn it in that sense, it makes it a lot easier to understand. E2, prostaglandin E2 is a vasodilator that inhibits T cell signaling and also dilates bronchioles. So it'd be the opposite of what's happening here, right? We want to constrict the bronchioles in asthma, not dilate. And then option E, thromboxane A2, that's also part of the COX pathway and stimulates platelet aggregation and constricts blood vessels. So great job if you guys got this one. If you didn't, it's okay. Try to learn from this. And even if you did get this one, a question can easily switch the question up to ask you about any of these other options. So be aware of that arachidonic acid pathway. Go back to first aid, take a look at it, and really just practice that over and over again. It's very high yield, especially for step 1, and it builds on a lot of the stuff that we need to know for step 2 and beyond. So great job, guys.
That is the way to get the session started. So good work, everyone. I can see everyone is focused, locked in, and ready for question number 2. So we're following the same method here, right? So we've got the answer choices covered up, and we're going to start by looking at that lead in, but you also notice the x-ray there. So obviously in respiratory questions, that's not unusual. So again, let's go ahead and read that lead in. Which of the following additional clinical examination findings is most likely in this patient? So again, reading that lead in, seeing the x-ray, you've already got quite a bit of context that you can bring to the vignette. So let's read that now. A 19-year-old man is brought to the emergency department after a motor vehicle accident. He has chest wall pain. Blood pressure is 70/52 with a pulse of 126. Physical examination shows diminished lung sounds on the right side. Hematocrit is 43.2%. Chest x-ray is shown. So again, which of the following additional clinical examination findings is most likely in this patient? Think about this one. Think about how many steps it's going to take for you to get to this answer as I pass it off to Abraham.
All right, so we have like kind of a older patient here, still 19, pretty young man. We're dealing with a different situation, and we got an X-ray to go along with it, and we'll kind of break down what's happening here. So let's go through, let's highlight, let's look at the lead-in one more time here, and let's figure out what we're dealing with. So we have additional clinical examination findings are most likely in this patient. So now again, not diagnosis, not treatment. It's asking about exam findings. So you want to think about, okay, what physical exam am I going to see in this patient? And what does that mean in the clinical context of the situation? We have a 19-year-old man and an MVA, right? Motor vehicle accident. A lot of things can happen in an accident. Comes in, he's got some chest wall pain. Blood pressure is 70/52. That's pretty bad. Tachycardia, 126. Physical exam. So far, they give you some physical exam, shows diminished lung sounds on the right side. Hematocrit is 43.2, okay, not too bad. And chest x-ray is shown. Look at the image here. I'm not going to point too much out right now, but we'll talk about it. And, you always want to use the physical exam and the clinical presentation in addition to the scans. You never want to look at the scans in isolation, right? This is not a radiology exam. This is step one. And you need to be able to see the full picture, and they always will give you a clue based on the vignette to point towards what to look for. So what area am I looking at the lung? What's something that I need to kind of understand in the situation, and where can I take that from there? So a couple important points here: understanding the clinical picture, understanding the acuity of his illness, and understanding what additional exam findings am I going to find. So let's look through, let's look at the options, and let's address this one by one. We have option E, tracheal deviation. Option D, muffled heart sounds. Option C, Kussmaul sign. Option B, increase in tactile fremitus. Option A, dullness to percussion. Now, all of these are associated with different things, right? They're not all just random options. These are clinically relevant options that you can possibly see in different situations. But only one of these is going to fit this clinical situation. And as small as a vignette is, they're giving you everything in this vignette is kind of pointing towards something that's very high yield in the situation. So take your time, read through the vignette one more time if you need to, and look at the x-ray and use that to come to an answer.
And we'll share the results. Okay, so not quite as strong of a response as we had for the first one, but almost half of you went with one of the answer choices. In this case, answer choice E, tracheal deviation. About 1 out of 5 of you went with dullness to percussion, and muffled heart sounds also got the vote of about 16% of you. Kussmaul sign and increase in tactile fremitus, yeah, just a handful. Okay, very good. Let's go ahead and close the poll or close the results and share the answer. And the answer is answer choice E, tracheal deviation. So again, really nice work here from the crowd. Two great responses here for the first 2 questions. So good job, everybody. But if you didn't get it right, that's okay. We're going to make sure you get it right on test day. So Abraham, take it away.
All right, great job again, guys. Again, this is a little trickier question, and it does involve an image and kind of using a physical exam finding to figure out what's going on. So tracheal deviation is the correct answer in this question. So let's go back. Let's look at the question. Let's try to figure out what the diagnosis is. Now, this is someone who is coming from an MVA, right? Your differential should be pretty wild. Lots of things can happen in a motor vehicle accident. You can have trauma to chest. You can have contusion of the lung. You can have a tamponade situation. You can have anything. Well, the big clues in this situation is that, first of all, he's having chest pain in the area. Okay, so you always want to look, okay, where is the chest pain happening? Blood pressure being low and pulse being up is very important for in this situation, right? So that shows that this is not just a simple issue. This is something that actually is critical. Like hypotension is a big finding that we need to be aware of. So chest pain, decreased breath sounds in that area, and that chest wall pain all together point towards there's something going on in that side. So remember, when we look at x-rays, the right and the left are flipped. So they may give you a little clue here on the top left of the screen, it says a little R there. So that's the right of the patient. So if I look at the actual lung, it should be dark, but not that dark. So if I look at the actual X-ray here, I see this little really dark area on the right side of the chest. And the left side has got the kind of the haziness on it, and you can kind of see the lung in there. The right side, however, it kind of looks empty in the chest. Where's the lung? The lung is actually kind of compressed here. So this is what we call a tension pneumothorax. Right. So how do we know it's a pneumothorax? How do we know it's tension? Well, the idea of a tension pneumothorax is that some kind of trauma occurred. Maybe he had some piercing injury, maybe he had his rib break. Whatever the idea is, that your body created a one-way valve. It means that air is getting into the chest cavity, but it can't escape. So it creates like this valve situation where the pressure on one side of the chest increases, and that's what creates that tension. That's what the word tension comes from. Tension pneumo is air in the thorax, right? Tension pneumothorax is high pressure air in the thorax. So if I look at the right side of that X-ray, right, which is that R side, so left side of the screen, right side of the X-ray, you see that dark area where their lung is not present, right? You want to see these markings whenever it's lung. But look on the left side, you can see the markings all the way to the edge. Here, that really dark area is just empty space. There's no lung there. There's just that pneumothorax that's there, and it's collapsing the lung. And that, some of the findings that prove that is hypotension, tachycardia, and the fact that when I try to listen to that side, air is not moving. I don't hear breath sounds. There's diminished breath sounds. So we got the diagnosis. That's the step one, right? Getting the story, getting the diagnosis, step one. The second step is, what's the physical exam I would expect in this patient? So here, let's go from A to E. This will be easier to understand. Dullness to percussion. Well, you want to think about what's dull. If I have a balloon and it's full of air and I tap on it, that's not going to be dull. Whereas if the balloon is full of sand and I tap on it, that's going to be dull, right? So dullness to percussion is when the lung is full of stuff. So for example, if the lung was full of fluid, you would hear dullness to percussion. So things like pneumonia, things like that, and the pleural effusions, you would hear dullness to percussion. Whereas a pneumothorax, it would be hyper resonant. It means that there's a lot of extra air. So it's like an echo almost. So hyper resonant is how they would describe A, the percussion. So that A is out of the picture. B, increased tactile fremitus. So tactile fremitus is a thing that you guys might remember from med school, where you put the hand on somebody's back, they say 99, 99, 99, but the idea is that it is going to help detect dense lungs, where you're going to have, it's in pneumonia, when fluid builds up inside the lungs, the density of the lung builds up, and that's what changes the noise that they make when they do it. So this is typically seen in, pneumonia and like sometimes heart failure as well. The idea is that you have increased fluid inside the lungs, and that's not what's happening here. So B is out. C, Kussmaul sign. So that's a sign of increased jugular venous pressure, or JV distension, with inspiration. There's a scene whenever we take a deep breath, blood tries to enter the heart, but the heart has failed and things are backing up. So things like right heart failure, tricuspid stenosis can cause it, any kind of constricted pericarditis, those are the ones that you want to look for C. And D is our good old friend, muffled heart sounds. If you go back to cardiology, this is our cardiac tamponade. Super high yield, understanding that, the heart is surrounded by fluid. So imagine I'm clapping my hands underwater. Do I hear anything? No. The idea is that the heart is doing the same. If it's drowning in its own blood, when the valves open and close, we're not going to hear it. So the heart sounds will be muffled in a tamponade situation. So what is tracheal deviation, and can we see it in this patient? Yes, we can. The pressure on the right side of the chest is going to be really high because of the tension pneumothorax. So it's going to push everything away. It's going to tracheal deviate away from it's going to go deviate towards the left side of the chest. And it's a little hard to make out in this picture, but if you can see that the trachea is you can kind of see that black line that runs from the chin down, and they think it's more deviating to the left side. But regardless, even if the X-ray doesn't show it, the picture fits with a tension pneumothorax, which we know would be associated with a tracheal deviation away from the side of high pressure. So high yield question, a lot of other little things to take away from this question as well, even if you got it right, but great job. And if you have any questions, you can drop it in the question bank, but good job, guys.
So let's go, and looks like we've got another X-ray for you. got the answer choices covered up. Let's read that lead in. Which of the following is the primary cause of this neonate's most likely diagnosis? So really, an interesting question construction here. And again, reading that lead in first, helps kind of provide a map through the vignette, which we're going to read right now. A newborn girl is evaluated for dyspnea after being delivered via emergency cesarean section at 30 weeks of gestation because her mother developed hypertension and seizures. The newborn appears cyanotic. Respirations are 70 and oxygen saturation is 68% on room air. There's nasal flaring, expiratory grunting, and intercostal retractions. No murmur is heard, and the neonate's X-ray of the chest is shown. So again, which of the following is the primary cause of this neonate's most likely diagnosis? Again, this is a good one for you to kind of form a hypothesis in your head, so that you have your own idea of what this answer might be before we even show those answer choices. So think about that as I turn it over to Abraham.
All right, so we're going kind of back to pediatrics a little bit, but very high yield question here as well. So we'll have to kind of understand it. You have a pretty crazy looking X-ray, which is important to evaluate, and as well as kind of history, right? So you want to use both to get to an answer. So let's go through, let's highlight, let's read the lead in one more time, and let's go through the vignette. Again, this is one of the more classic questions. What's the primary cause of the patient's most likely diagnosis, right? So you have a cause, diagnosis, right? Very typical step one style question, the most common actually for step one. So you want to think about the presentation and then try to figure out what's happening. What's the primary cause of the diagnosis? Okay. A newborn girl, we know that, has dyspnea. Now she was delivered by a C-section at 30 weeks gestation. So what does that mean to you guys? Mother had hypertension and seizures. What does that mean to you guys? And the newborn is cyanotic. Okay. Respirations are 70. Oxygen saturation is 68%. Okay, that's not great. Nasal flaring, expiratory grunting, intercostal retractions. All bad signs. X-ray, they show the X-ray here. I'm not going to go reading too much into it just now, but I'll wait till we get the answer. But as you can see, this is not a normal X-ray. There's some things that should be standing out to you guys. And we're looking at a chest X-ray here. So in this baby who was just born at 30 weeks gestation with a mother who had hypertension and seizures and is now cyanotic and hypoxic, what do you think is the cause of the patient's most likely diagnosis? Let's pull the options up here and we're going to go through it one by one, okay? So we have option choice E, a right to left cardiac shunt, okay? Option choice D, impaired diffusion. Option choice C, impaired chest wall movement. Option choice B, diffuse atelectasis. Option choice A, delayed clearance of fluid. So you have your diagnosis from the history here, but it's asking about the cause of the underlying diagnosis. Okay, so you got to think about the steps in this question. Trying to figure out the underlying diagnosis first from the story. Then think about, okay, what out of these options would cause that diagnosis? And what would match the X-ray to kind of finalize and confirm your answer? Take your time. Look at it one more time if you need to. See the big picture. And go ahead and pick the answer you believe is the best answer in this situation.
Okay, let's see. Okay, I think about 78% here have voted. So we're going to go ahead and end the poll. And let's share the results. I don't know, this has been a pretty confident crowd here tonight. Not seeing a mixed bag often. at least half of you going for one choice over the others. In this case, that was with answer choice B, diffuse atelectasis. Some of you went with impaired diffusion, and then a few went with delayed clearance of fluid, impaired chest wall movement, and right to left cardiac shunt. But again, seem to have pretty good consensus here. So I'm going to go ahead and close the poll. And let's reveal the answer. And the answer is indeed answer choice B, diffuse atelectasis. So nice job, everyone. Gosh, overall, the scores would be pretty high based on tonight's results. But let me stress that it's not about tonight. Tonight is all about learning. So if you've gone 0 for 3, that's quite all right. This is really the time to focus, especially maybe you haven't fully gone through your respiratory block yet, or maybe you're still going through it. So that's quite all right. And that's why Abraham's here, because he is going to walk you through the path to the answer. Abraham.
All right, great job again, guys. Again, this is another question that's a very high yield one. I know a lot of you guys got it right, but I just want to make sure that you guys have this locked down and understood really well. So let's, again, break down what's going on in this patient. Let's figure out, what the situation is. And let's look at the vignette one more time. We have this newborn girl with dyspnea. Okay, so it could be a multitude of things, but she was born at C-section at 30 weeks. So that's already, she is premature in that situation. She has a mother with hypertension and seizures. So what should that make us think of? Hypertension and seizures. So that kind of fits with, it depends on if she has proteinuria and stuff, but kind of fits with the history of, someone having eclampsia, preeclampsia, that kind of route. So eclampsia route. So that puts maybe at her higher risk there. She's cyanotic, right? So that's of course concerning, and oxygen 68%, which is not good. So she's working real hard to breathe, nasal flaring, expiratory grunting, intercostal retractions. And then you see this x-ray, complete whiteout, right? We can't even tell where the lungs are and where they end. It's complete whiteout, and this is a typical situation of neonatal respiratory distress syndrome, right? NRDS, right? We know about the ARDS, ARDS in adults, and that's typically what we see when we talk about like post-COVID infection. People get that. People get ARDS with pancreatitis or any real bad sepsis situation. But this is a different type of respiratory distress syndrome called neonatal respiratory distress syndrome. Most commonly seen in premature neonates. And why would that happen in premature neonates? What about prematurity puts you at high risk? So you want to think about it in this way. So, in the last few weeks that the fetus spends in the uterus, they start developing this compound called dipalmitol phosphatidylcholine. It's a real long word, but the idea is that it is one of the important components of making surfactant. And what is surfactant? Surfactant is like something that we love to have inside our lungs, right? It decreases that surface tension inside of the lung and prevents collapsing of the lung, right? We have to understand when our lungs are essentially balloons. We're making it bigger, making it smaller. But how do we prevent that balloon from collapsing on itself? And that's what surfactant does. Surfactant keeps that surface tension low inside and acts kind of like a soapy liquid that keeps the lungs nice and open and prevents it from collapsing. So in this situation, when you don't have that, that's when you get multitude of alveolar collapse because of the increased surface tension. And that's what atelectasis is. Atelectasis is just lung collapse. So diffuse atelectasis is another way of saying lung collapse in all of your lungs, which is secondary to a deficient in surfactant. Because the baby was born premature, they didn't develop enough of that compound to make more surfactant. Now, some of the other options here are pretty good, and you want to think about, okay, what could these other be? When we think about delayed clearance of fluid, this can be typically seen when, babies are born, they're in amniotic fluid. They have to get rid of that fluid that they're surrounded in. And, that can happen sometimes, and that can lead to tachypnea initially when they're born, but it wouldn't be this. It wouldn't be cyanotic. It wouldn't be this kind of typical presentation that fits with the atelectasis. The x-ray is not going to look like that. So it's usually a transient tachypnea of newborn, right? So as soon as they're born, they're like, oh, they have this like initial respiratory distress and it goes away. But you wouldn't have x-ray that looks like this, and they would resolve pretty quickly on its own. So this x-ray is what points it away from delayed clearance of fluids and tachypnea of newborn. Impaired chest wall movement. Okay, so what would prevent the chest wall from moving up and down like that? Well, you would see some skeletal deformities, right? So if there's some really severe skeletal deformity that they're showing there, they'll usually give you a history of like pectus excavata. They'll give you real bad scoliosis. Although in this picture, the baby is a little curved. It's not severe scoliosis that would prevent the lungs from expanding. And then let's look at the next option here. We have impaired diffusion. A lot of you guys picked that. And technically, in these situations, you would think your diffusion, it would be impaired in a certain way as well, right? There would be reduced gas exchange and everything. But that is, the question is asking the primary cause. The impaired diffusion is more of an effect of the atelectasis and the poor, the collapse of the lungs. The impaired diffusion, you want to think more about things like your critical congenital heart diseases, where you just can't have, you have these problems getting oxygen into your body through diffusion. And that's what they're really focusing on when they're talking about impaired diffusion in those situations. Again, does not really fit that. There's no murmurs, there's no like something else pointing towards one of the critical congenital heart diseases, which would be the main thought. And then right to left shunt, these are also falls into that category: tetralogy of Fallot, transposition of great vessels, tricuspid atresia. All these cyanotic heart diseases is what you're going to be thinking about with that. So kind of D and E kind of fall into the same category as well. And then in this situation, the question is the primary cause, and the diffuse atelectasis is the cause of the NRDS in the situation. But good job, guys. High yield question, understanding this, looking at this x-ray. In neonates, think about NRDS. In adults, think about ARDS. Great job.
Okay, nice work, everybody. We've made it to the end here. We've made it to question 4 here in the cleanup spot. Those of you who are question lab regulars, many of you know that this is often the more challenging of the questions of the evening. We'll see if that turns out to be the case. You guys have been knocking it out of the park so far. So again, we've got the answer choices covered up. Let's go ahead and read the lead-in. Which of the following is the mechanism of action of the agent most likely causing this patient's symptoms? So a multi-step question here, right? You're going to have to figure out what's going on with this patient, what agent is causing their symptoms, and then the mechanism of action of that agent, which is most likely causing the symptoms. So a lot to pick apart. So with that, let's go ahead and read the vignette. A 30-year-old man is brought to the emergency department because of shortness of breath, dizziness, nausea, vomiting, and palpitations after entering a burning building to save his neighbor 2 hours ago. On physical examination, pulse is 90, respirations are deep and gasping at a rate of 30 a minute, and blood pressure is 80/60. He has bright red vessels in the retina of both of his eyes and an unusual acrid odor on his breath. So with that, the question again, which of the following is the mechanism of action of the agent most likely causing this patient's symptoms? A lot to pick apart. Glad we've got Abraham to help lead the way.
All right. Well, we got a little bit different question here. This is, again, we're in the last question here, so it's going to be a little more challenging than the rest. It's a mechanism of action question. So let's go through, let's highlight some keywords here. Let's figure out what we're dealing with before we look at the options. Again, mechanism of action of the agent causing the patient's symptoms. So what happened? What did he get exposed to? And how does that agent work? We got a 30-year-old man. He came and went. Shortness of breath, dizziness, nausea, vomiting, palpitations. Okay, could be 100 things, right? Just with that. But he recently entered a burning building to save his neighbor. Okay, that's important for us to know. Pulse is 90, so it's pretty high. Gasping rate at 100 per minute. So he's trying to take deep breaths. He's trying really hard to breathe. Blood pressure is 80/60. Okay, it's on the low side. And he's got bright red vessels in the retina of both of his eyes. An unusual, acrid odor of his breath. What does that mean? Acrid odor of the breath. So we have this clinical situation, very unique, but very much high yield. So you want to think about what happened that got him to have this kind of clinical presentation, and then what that mechanism of action was to that agent that he was exposed to, which is causing this. So take your time, think about what this agent could be, think about the mechanism of action as we pull up the options. All right. Option choice E, uncoupling of the electron transport chain. Option choice D, inhibition of the electron transport chain. Option choice C, inhibition of an ion channel. Option choice B, inhibition of the adenosine triphosphate synthetase. Option choice A, decreased blood oxygen carrying capacity. All right, so again, very basic science heavy, asking you at a molecular level what's happening. This is classic step one, where they want you to not only know, okay, the clinical side of it, but also you want to be able to understand the basic science and understand what's happening at a molecular level in this situation. So take your time, think about what all this could mean, and go ahead and pick an answer.
About 3/4 of you voted, so just a few more seconds, and then I'm going to close the poll. I know we're close to the top of the hour. Some of you may be staying up pretty late. Some of you may be up real early. So I'm going to end the poll and share the results. And let's see, it looks like sort of a two-horse race here. Decreased blood oxygen carrying capacity came in first with about 38% of the vote. Inhibition of electron transport following that at 32%. And then uncoupling of the electron transport chain and inhibition of adenosine triphosphate synthase, kind of bringing it up. Nobody went with inhibition of an ion channel. Okay. So I'm going to close the poll. And let us answer it. And the answer is answer choice D, inhibition of electron transport port. Sorry. Looking at the poll, I saw that there wasn't a space between the answer choice D and inhibition. I don't know if that gave it away for anybody, but just notice that. But regardless, nice work, everybody. Not everybody got this one, and we knew this was going to be challenging, and that's why Abraham's here to explain what was going on with this one. Abraham.
All right. Well, nice try, guys. I know a lot of you guys got this right, but a lot of you guys did not. So this is a very high yield question to go over. And I get why you guys picked option choice A and E as the second and third choice options. And those are definitely a good distractor in this situation. And, they can present very similarly, and one is just worded a little differently. So let's first break down what's going on, right? What is causing this patient's problems? So the patient is a 30-year-old guy, comes in after running out of a burning building, right? When I think of burning building and exposure, there's two things that come to mind, right? Number one is cyanide poisoning, right? So synthetic products, right? Things that are like, a lot of plastics and things like that. When they burn, products of combustion, they release cyanide into the air. And when cyanide gets into the patient's lungs, they get absorbed, and that can lead to a lot of complications. Of course, carbon monoxide is always something we always worry about too. This tends to be less in fires and more in smoke, furnaces, space heaters that builds up. But regardless, sure, it could be either or at this point based on the clinical presentation. They're tachypnic, their pulse is high, and their blood pressure is a little low. And you have these red eyes in the retina, and why is that happening in the first place, right? So bright red blood here. But the big thing here to understand is that the acrid odor in his breath. That's very classic, right? What is acrid odor? Acrid odor just means bitter almonds. So, that flushed appearance, which can be seen in both cyanide and carbon monoxide, can be tricky, but this flush is more classic for cyanide in the first place. But also, the bitter almond breath is very classic for cyanide poisoning. So you want to understand the full story in this situation. So we're dealing with a cyanide toxicity in this situation. The history of the recent smoke exposure, the shortness of breath, dizziness, acrid breath odor. You have those are the typical presentations that these people present with, the flushing and the headaches. So that's step one, right? Understanding the diagnosis. I know a lot of you guys were thinking carbon monoxide, but this is actually a cyanide poisoning. Okay. Well, let's go through the options. Let's figure out what's going on. So option choice A was what a lot of people picked, and that is carbon monoxide poisoning, right? So decreased blood oxygen carrying capacity is characteristic of carbon monoxide poisoning, right? So when I have carbon monoxide build up, it's going to compete with oxygen for hemoglobin spots, and your ability to carry oxygen in the hemoglobin goes down because carbon monoxide, it's like playing musical chairs with oxygen. It always takes a seat away from oxygen. So it takes away the spot of the oxygen. Therefore, your body's ability to carry oxygen around your body goes down. They do not have this acrid breath that's typically seen in cyanide toxicity. So that's a big clue here that differentiates. And then also, the general presentation with a burning building, I tend to see a lot of those to be more cyanide poisoning as opposed to someone using a space heater in a garage. That's going to be more carbon monoxide poisoning. Okay, let's go number B, inhibition of ATPase, essentially, adenosine triphosphatase, ATPase synthase. Now, this is going to be drugs like oligomycin. It's kind of a less high yield drug that we use sometimes, and this is how it works. So nothing to do with cyanide toxicity. That's not how it presents in this situation as well. Inhibition of ion channel, 0 people pick that. It's going to be down with the neurotoxins like the tetrodotoxins and stuff like that. Not what's happening here. Uncoupling of the electron transport chain. So there's 2 electron transport chain options. So even if you thought it was electron transport chain something, you needed to know it was inhibition, not uncoupling. So when I think of uncoupling, there are these agents like 2,4-dinitrophenol, which are like these agents which used to be used at one point for weight loss, but now it's actually we don't use them anymore. It's the idea is that you're going to try to it uncouples a lot of the agents in the electron transport chain. Therefore, it inhibits the ATP generation. So you just run this electron transport chain consuming energy without creating ATP. So it was the idea was that, you would burn more calories that way. But then, a lot of complications came from that. So then that became not agent we don't use anymore. But coming down to the actual option here, inhibiting electron transport chain. So this is what's happening in cyanide poisoning. So this is happening at a very molecular level and very important for us to understand. It actually works in the complex 4, right? Also known as the cytochrome C oxidase in the electron transport chain. So this is important for cellular respiration. So for oxidative phosphorylation, going back to your biochem, right? Thinking about that cellular respiration in the mitochondria, we need everything in the electron transport chain to work well. And when I block that complex 4, which is a cytochrome C, then everything shuts to a stop. And therefore, the ATP demands that it's trying to create, it gets shut down. So therefore, patients will have all these other symptoms. Their body is trying to compensate for the fact that their body can't create ATP through oxidative phosphorylation. And that's what causes all these issues. So very important to understand that situation, very important to kind of evaluate the whole thing and go from there. How do you treat these people? This is a little bit extra, we'll kind of say this food for thought. There are questions about this as well. The idea is going to be, first thing you want to do is, you want to decontaminate the patient, take off their clothes and take off things that would have cyanide exposure to it. Giving oxygen is not really the answer in this situation. That's why it's very important to separate between cyanide and carbon monoxide. Carbon monoxide, oxygen is the answer. Give them oxygen, oxygen, oxygen. Your goal is to overwhelm the carbon monoxide with oxygen in the body. Whereas in cyanide poisoning, the problem isn't that there's not enough oxygen. The problem is inside the actual mitochondria, your cyanide is binding to things. So you want to give something like hydroxycobalamin, which binds to cyanide. You can give nitrates and sodium thiosulfate.
So a lot of these other agents, which are also listed in your first aid, you should review those and kind of understand what we do. So the 3 options would be hydroxycobalamin, nitrates, and sodium thiosulfate. Those are your treatments for cyanide poisoning. Always think about it when you think about burning building, coming out. And then acrid odor is going to be the big buzzword here. That's very important for you to know. But great job, guys.
Yes, excellent work, everybody. And thank you for all of the walkthroughs tonight. Abraham, very helpful. Again, just happy we're able to bring together this community and work through these board style questions. If you want to take another look at any of these items, we've got the test for you. And in fact, I can see if I can